you put out probably one of my favorite publications ever because it really translates to us in the chair, the injector treating a patient. And you put out a publication on focal accumulations of CaHA and non-inflammatory nodules and why they happen and your algorithmic approach to how to treat them if they were to appear. And it was such a beautifully written publication because you made it so digestible for me as the provider, like I said, without a research background. So I would love for you to kind of explain why these focal accumulations or these non-inflammatory nodules happen and how do we tackle them if they were to show up with our patient.
Yeah, well, thank you so much for the feedback on the publication. That's always awesome to hear. That's, someone is getting something out of your work. Yeah, I'll get right into it. I'll start with this. Most nodules and biostimulators are non-inflammatory focal accumulations. So a colleague and a co-author on this paper, David Funt, has an awesome article on HA nodules where he describes, I think, a difference. He does a great job describing the difference between inflammatory and non-inflammatory nodules. But non-inflammatory nodules generally are not characterized by excessive swelling or redness or even pain. They generally aren't delayed onset. They're probably going to look like superficial placement. You might see them in a cannula track line. And, they're if you look histologically, they're not characterized by an abundance of immune cells. So they're not generally looking like histologic granulomas. And most of the time, these are technique related. Migration, obviously, with any injectable can happen, but in most cases, when you're dealing with a biostimulator, you're probably dealing with a focal accumulation. And what I mean by that is we basically just have a lot of microspheres in one spot. And now the question is, how do we get rid of them? Or how do we prevent them? So, I think respect depth, and especially if you're pushing a bolus. A surgeon colleague of mine made a great analogy a few years ago to me that was like, you're never going to feel a marble under a mattress. And I was like, okay, that's a really good point.
Genius.
So, yeah, genius point. So be mindful of the volume and dilution relative to the plane that you're in, right? So undiluted CaHA is usually, let's say, jawline placed on the periosteum. And to me, that makes sense, all right? You're probably not going to visually see a nodule there. Avoid injections around sphincteric muscles, around the eyes and the lips and mouth. Favor a slow push massage post-injection if that's the goal, to get a good spread. But anyway, those are pretty common sense, I think, for prevention. Now, management, a really important one, level 0 in our protocol, and we had 3 levels, well, actually 4. Level 0 is essentially watchful waiting, right? So I think there are a lot of people that can palpate a non-visible nodule and are maybe concerned, but if they're not really bothered by the fact that they can palpate it, right? It's not visible or cosmetically distracting. The recommendation in the publication was to wait. These things do resorb. Level 1, and I generated some data on this with a colleague in Florida, Shoham Berkowitz, on mechanical dispersion. I'm definitely partial to this. We borrowed the concept from lithotripsy. And, so our level 1 concept was you can disperse this with saline. We know that. You can hit a nodule with saline and sort of get some disperse it. And I think that works quite well. The literature would suggest that 1 session of just saline dispersal will reduce nodule volume by around 30%. So, that obviously would mean repeat sessions, but maybe not that big of a deal. So our concept was, okay, well, how do we increase the efficacy of aqueous dispersion, right? There's no pharmacologics, no energy-based devices, arguably like a lower risk of complications. And our solution was you impart mechanical vibration after you inject a solution. And again, the concept was really based on lithotripsy. So you create sort of an in situ slurry or suspension. Now the goal is to use percussive vibration to resuspend the particles and basically shake them back into the suspension that you've created, with the hopes that as the saline is resorbed, the CaHA microspheres are resuspended uniformly and settle flat. And we've gotten pretty good results with that. I've seen some people use microneedling devices to impart vibration, right? So something like skin pin or even a Theragun. I've had a lot of people use Theraguns to work with it. Yeah, right. I've also seen in this level 1 Tixel used as well, sort of in the same combination. But if those fail, sorry, did you have a question?
No, my Theragun is pretty powerful. I can't imagine.
Yeah, and it's a good point, but I think the really important thing is it doesn't have to be deep vibration. And
Right.
if you're
It could
using a
just be like,
microneedle, yeah,
yeah.
yeah. And if you're using a microneedle, it's not the actual needles themselves penetrating the skin that's doing the work. It's basically the hitting of the skin itself.
Interesting. I've never even thought about that using those devices.
Progressing through this algorithm, if those fail, or if the patient presents maybe months after they've noticed a nodule, now we have a new consideration, right? You now have deposited collagen and elastin, probably anchoring these particles in place. This now becomes quite a bit more difficult to treat. And credit to Shino Bay, he came up with probably the most widely used protocol for biostimulator nodules with CaHA and PLLA. So Shino's protocol was in our level 2. This is a pharmacological intervention with intralesional 5-FU and triamcinolone and Dex. And similar approach to aqueously disperse it. I think his concept is nice. Turn off fibroblasts and neocollagenesis. Try to preserve cell function. And it's shown some efficacy. The other two options that we had in level 2 was ultrasound guided delivery of collagenase, especially if you have dense collagen post injection. And then actually a really nice approach in our level 2 is using lasers. And the two lasers that were used were fractional CO2, and the anatomical areas were in the tear troughs. So this is gentle skin, thin, gentle skin that might be difficult or prone to, worse damage from a microneedle or from, an intralesional injection. And that actually works in the literature, appears to work quite well. Anyway, if all three of those levels fail, the third level was physical removal. So this would be like they're super persistent, the patient is really unhappy, or there's an emergent need to remove it. I think the most obvious was lancing and expressing it out with the needle. And, probably fairly low risk, maybe tedious if there are a lot of nodules. That's a lot of pokes. But, I think the literature that we cite in the paper, not bad. It's, the results are quite effective. One of the studies that we cited accessed the nodule through the oral mucosa, right? So now you don't even have like an externally facing puncture. So they basically just squeezed it out into the mouth. And then the last step in level 3 is a great paper called Radiesse Rescue, where it was the removal of a very large bolus of Radiesse. And they actually used a mini liposuction cannula with negative aspiration. So they attached it to I think 5 ml syringe, pulled the plunger back, and basically just aspirated the Radiesse straight out. The authors wanted to be clear on the level 3s that, a scar is permanent, but these nodules are not.
That's so true. I've probably experienced in my whole career 3 nodules. The first one, I had the same conversation that you had. It wasn't visible, and I told her, I'm like, listen, we are in the field of aesthetics, and if I can't see it and it's not bothersome, if you could feel it, I understand. If it's really bothering you, we'll tackle it. But if we can't even see it, let's leave it alone. And ultimately, I've seen her routinely for her tox treatments, and it resolved on its own, and it was fine. The other 2, I performed a little subcision and flushing, and it cleared up with 1 treatment. I did some kind of, I wouldn't call it aggressive massaging, but really like blending it down, flushing it, subcising it, and it was gone within that treatment. I didn't even have to perform a second treatment on it. So really that first level can kind of clear up a majority of them if you were to experience them. And as those were really much more so in the beginning of my career before I really understood how to inject this product appropriately in what area, whether on periosteum or subcutaneous, really understanding how it performed in tissue and my depths. Since I've had a really good understanding of how to use this product, I haven't experienced a single non-inflammatory nodule. It really was prior to my two that were visible were in the DAO region. And I think I placed it too superficially where that DAO and DLI are overlapping, and it kind of compartmentalized in between those two muscles. And because that tissue is rather thin there, and you know my demographic in the villages, it's very mature. So they have very thin tissue. It was more visible. It was small, but it was visible. But it really did clear up with that first level of subcision flushing and massage. And I haven't experienced it since I really started getting a better grasp of how this product performs.
Yeah, that's super good insight. That's exactly why we placed that approach as a level one. It seemed like most people that I interact with tell a similar story where they get good nodule resolution, basically just with subsizing, vibration, and flooding. And right, that's pretty low cost, pretty low risk,
Mm-hmm.
and relative to the other interventions, and seems to work quite well.
Mm-hmm. Yeah, I haven't had to go beyond that. And I haven't really had many colleagues have to go beyond that either. I really do think that that's a powerful level where you can clear up 99% of them. And obviously, using intralesional steroids, you have to worry about atrophying that tissue and stuff. You really want to see if it were me in my practice and let's say I couldn't clear it up with one treatment, I would just give it a little more time. I do feel like it'll really soften up with that subcision flushing and massage. And then you give it like 30 days, bring them back and look at it. And I think at that point versus progressing into the next level, I would kind of just give it some time because I really do believe they resolve incredibly well on their own. So I always, especially for a newer provider, always educate them so that they can avoid them. And I don't sweep anything under the rug. And I like to air out all the elephants in the room and talk about the potential risk of these non inflammatory nodules with Radiesse. But I also educate them on the ways I've learned to avoid it. And hopefully they don't experience it at all because they're injecting the right depths, the right dilution for that depth and all of that. So I think it's just getting that education out so that people don't get that bad experience with this product when I truly believe it was really technique based and it could have been avoided.
Yeah, I think you make great points. Prevention is key. Knowing the product is key, and also knowing that there are solutions in the literature to help someone through dealing with these, right? And they're not permanent.